this video, we will be discussing agents used for the treatment of systemic lupus erythematosus, or I'll call it SLE moving forward, and we will add a number of additional immunosuppressive agents to your list of ones we have already discussed in this block. And before we dive into the mechanism of action and pharmacologic considerations for these agents used to treat SLE, we will first go over a very simplified overview of the pathophysiology behind this disease. So SLE is a systemic autoimmune disease with multi-organ involvement. For example, like some of the agents we're going to discuss today will be for lupus nephritis specifically. So one of the key characteristics of SLE is the production of autoantibodies directed against nucleic acids and their binding proteins. And this leads to a loss of self-tolerance. So how do we get to this loss of self-tolerance, and what are the primary players? So the etiology of SLE is complex and multifactorial, and there are a number of immune system dysregulations impacting both the innate and adaptive immunity. But it's thought that this begins with the defective clearance of apoptotic cells by macrophages. So this defective clearance leads to the overexposure of nucleic acids and their associated binding proteins. And we'll use DNA as our example for today. And this DNA can be taken up and lead to the activation of plasmacytoid dendritic cells, or PDC, which I'm showing you here. And this cell type is able to secrete large amounts of type 1 interferons, like interferon alpha, for instance. And these interferons will bind their respective receptors. And these type 1 interferons are pleiotropic, meaning that they lead to a number of immunomodulatory effects, like triggering the maturation and activation of other dendritic cells, which are antigen-presenting cells that can then present that exposed DNA to T cells to start this cascade of activation and differentiation of a wide array of immune cells that can mount a response against autoantigens. And one cell population I want to highlight specifically are the B cells, which can become plasma cells, leading to the production of those autoantibodies characteristic of SLE. But importantly, interferon alpha promotes the production of B lymphocyte stimulator. And B lymphocyte stimulator activates signals for B cell survival and maturation, and is elevated in SLE, propagating that humoral response, working in tandem with that cellular response to lead to that loss of self-tolerance. So moving to the next slide. So based on this mechanism of disease and the diverse cellular populations involved in this autoimmune disease, immunosuppressive agents are going to be necessary to mitigate this inappropriate and amped up self-targeted immune response. So similar to immunosuppressant videos, we will start off with the agents working outside or on the surface of the immune cells, and then work our way intracellularly, which means the first agents that we are going to be discussing again are going to be our biologics. And the first agent will be rituximab, which is a chimeric monoclonal antibody, but the central TU actually denotes this as a tumor targeting agent, because this agent is not only used in SLE, but it is also used for B cell non-Hodgkin's lymphoma, which is a B cell issue. So this agent is targeted at the B cell population, specifically at CD20. And CD20 is an antigen that's found on pre and mature B cells, and when bound by rituximab induces apoptosis of these targeted cells so that they cannot become plasma cells to secrete those autoantibodies, which are a significant driver behind the loss of self-tolerance in SLE. So despite this critical role of B cells in SLE, clinical trials did not reveal much of a benefit of rituximab for these patients. So it is reserved more for refractory cases that do not respond to other immunosuppressive regimens with more established benefit. And because of this limited applicability and because it shares a lot of adverse drug reactions and concerns with other monoclonal antibodies, we will just go ahead and move on to our next agent, which is belimumab, which is a human monoclonal antibody against an immunomodulatory molecule, specifically our B lymphocyte stimulator molecules. So this monoclonal antibody will bind soluble B lymphocyte stimulator to prevent it from binding its respective receptor on B cells. And remember, B lymphocyte stimulator is critical for the proliferation and survival of B cells. So we are essentially depleting the B cell population and preventing their conversion to plasma cells and that autoantibody production. Again, same general adverse drug reaction profile as other immunomodulatory monoclonal antibodies, in addition to the risk of depression. And our last agent for this slide is anifrolumab, which is relatively new and is a human monoclonal antibody against an immunomodulatory molecule. Specifically, we are targeting the type 1 interferon receptor or the interferon alpha receptor. So this binding inhibits type 1 interferon signaling, like that from interferon alpha, thereby blocking the activity of type 1 interferons at target cells. And this also induces the internalization of interferon alpha receptor subunits, reducing the levels of receptors available on the cell surface. So blockade of this receptor inhibits interferon responsive gene expression as well as downstream immune processes. So we block plasma cell differentiation, we block T cell responses, and because of the key role interferon alpha plays in SLE, this is approved for moderate to severe SLE and will come with the usual adverse drug reactions expected for an immunomodulatory monoclonal antibody. So moving to the next slide. So now that we have discussed the antibody-based agents used for SLE, let's move inside the cell and discuss the remaining agents we will cover in this video. So moving to the next slide. Now the agents already included on the slide should look very familiar from the allograft rejection video from earlier this block, where we went over the mechanism of action and important pharmacologic considerations for steroids or glucocorticoids, azathioprine and mycophenolate mofetil, and calcineurin inhibitors. And I just want to point out that there is one specific calcineurin inhibitor that has been approved for lupus nephritis we didn't talk about before, called voclosporin. So just so that you're aware. And these different agents will be applicable for certain SLE patient populations. So steroids will be similarly used for ideally short term for disease flares, whereas these other agents will usually only come into play for major organ system involvement, or as steroid-sparing agents to get the patient off steroids but keep flares at bay. So because we've already discussed these agents or these classes in depth, we will move on to other agents that are used in SLE. But I would encourage you to test your knowledge and, if needed, revisit the allograft rejection video for a nice review. So we will start off with methotrexate, which is commonly abbreviated MTX, which we discussed back in block 3 for IBD. And this is a steroid-sparing agent that falls in the anti-metabolite category with mycophenolate mofetil and azathioprine. And methotrexate inhibits dihydrofolate reductase, which is a critical enzyme that is needed for the conversion of a folate to its active form to participate in the synthesis of nucleotides. So by inhibiting this enzyme, methotrexate interferes with DNA synthesis and cellular replication in rapidly dividing cell populations like our lymphocytes. So we end up with immunosuppression. So similar to the other antimetabolites, this was originally a chemotherapeutic agent. So the adverse drug reactions for this agent will be very similar, where we're hitting those rapidly dividing cell populations, like our bone marrow, leading to suppression. There's also going to be GI toxicity, alopecia, infection, and malignancy, as well as with methotrexate specifically, there is a risk of hepatotoxicity and pulmonary toxicity. So our next agent is going to be an alkylating steroid-sparing agent known as cyclophosphamide. And you also might hear this called a nitrogen mustard. And cyclophosphamide is activated to phosphoramide mustard, which can alkylate and bind many intracellular molecular structures, but its primary target is DNA, where it leads to the cross-linking of DNA strands. And this will disrupt DNA replication, leading again to this targeting of these rapidly dividing cell populations, like our immune cells, leading to that potent immunosuppression. So same adverse drug reactions from hitting those rapidly dividing cell populations. And this agent also has a risk of pulmonary toxicity. And it also has a risk of bladder toxicity. So both this agent and methotrexate are similarly used as these other agents, where they will usually only come into play for major organ system involvement in SLE or as a steroid-sparing agent to get the patient off steroids but keep the flares at bay. Now there is one last agent we need to discuss, and that is hydroxychloroquine. Which is an anti-malarial drug that is commonly used for autoimmune diseases like SLE. So the precise mechanism by which hydroxychloroquine exhibits activity is not completely understood, but it is thought that hydroxychloroquine, which is a weak base, exerts its effect by concentrating in lysosomes. Altering lysosomal pH to where it inhibits the activity of many enzymes so that antigen processing and presentation is impaired, as well as just general cellular functions relying on the lysosomes is impaired with hydroxychloroquine treatment. So this is thought to lead to a number of anti-inflammatory effects like reduced lymphocyte proliferation and chemotaxis and cytokine production. And this agent is a good option for mild to moderate disease with more joint and skin manifestations because it does not come with the same sort of risk profile as some of the other agents we discussed on the slide. However, it does come with its own risks that can be severe, like irreversible retinal damage, prolonged QT interval, and the risk of arrhythmia, as well as that bone marrow suppression. So being aware of these and monitoring for them will be very important. So moving on to our summary slide. So that concludes our discussion of the immunosuppressants targeting intracellular components of immune cells, and we will continue to add agents as we go throughout the block to the schematic. So moving to the next slide. So now I hope this video has introduced you to a few more staple immunosuppressant agents that we will again continue to revisit throughout the block for other indications, as well as a few specific agents used mostly for SLE. And hopefully this video has continued to reinforce the pharmacologic similarities across groups of immunomodulatory agents, like mechanism of action or adverse drug reaction profiles. And these will continue to help you organize the different immunosuppressants and continue to become more and more comfortable with their pharmacology.